Hello everyone, welcome again to a summary of principles underlying the total hip replacement for surgeons in training. Adapted from Understanding Primary Total Hip Arthroplasties by Alan Hammer, 1997, a part 2 video, where this video will cover mostly about the approaches to the hip joint region. We started off with patient selection. Generally, the affected individual complains of pain in his or her hip accompanied by functional disability in as much as walking and climbing are difficult. The radiograph of the hip shows disruption of the joint space. There are, however, a few cases where caution should be exercised. Number 1, a young patient, and in particular, heavy patients, are not ideal candidates for total hip arthroplasty as excessive stress is placed on the bone or cement or the prosthesis interface, leading to an early wear and loosening. Number 2, patients who are overweight or are on hormonal replacement or have a history of previous deep vein thrombosis or other vascular problems, as this patient may develop undue post-operative complication. Number 3, autocontamination with bacteria is a potent source of infection and people with overt or covert sites of infection. Example, patient who has a bronchitis or urinary tract infection. This will jeopardize their operation, as well those with patient who has previous infections of the hip due to presence of bacteremia. Number 4, it is not wise to operate on an individual with a bleeding diastasis unless one is in a situation to control this bleeding tendency. For operative technique, having obtained a patient who requires a total hip arthroplasty and selected the most appropriate prosthesis for the patient, so next, how do we proceed? We must remember all the general surgical principles must follow this. First, ensure of clean wounds, ensuring hemostasis, gentle soft tissue handling, and if possible, dissection through the tissue planes. The first technique involved is templating. Pre-operatively, template can be used with the radiograph to estimate the approximate site, size, and seating of the components to be used, and in determining the site of the neck cut. Particularly when the posterior approach is used, as it is difficult to measure the leg length during the operation using this approach. Operative correction of the deformities of the diseased hip are made by superimposing the template over the normal side of the X-ray of the pelvis. Tracing made of the combined template and the hip outline are transferred onto the abnormal side to indicate the cuts and the final estimated position of the components in the corrected hip. In cases of bilateral osteoarthritis of the hip, both legs are shortened, and one should not assess the operated leg against the opposite one. In this case, to obtain an optimal tissue tension, the operated leg should be slightly longer than its fellow after surgery. Second, regarding the theatre environment. Infection of the prosthesis after insertion is a disaster. and all measures to prevent this disaster should be taken. Ideally, a laminar flow theatre should be used if available in vertical or horizontal flow. In some of these operating rooms, totally enclosing a Charnley suits are also worn. Theatre discipline is important. A clean theatre clothes with full head hoods and face masks should be worn. The movement of people into and out of theatre should be limited. Consider a skin preparation carefully. The cleaning solutions, the method of draping, and the type of barrier sheets used should all be carefully selected. The skin preparation usually contain either iodine or chlorhexidine and may be water or alcohol based. Alcohol is a better disinfectant, but a water-based solution is better if you wish to use a detergent solution. Draping is often a matter of personal preference. The legs should be free draped and wholly available. Skin adhesive barriers drape, particularly those impregnated with iodine compounds, markedly reduce the contamination of the wound by skin organisms. Although the operation usually takes place in a septic surrounding, prophylactic antibiotic cover should be administered during surgery. The surgical approach. There are several surgical approaches to the hip which may be used to insert a total hip arthroplasty. The approaches utilized may be from anterior, lateral, or posterior. The selection of the approach most often depends upon the preference of the individual surgeon. Whatever approach is used, correct positioning of the patient is essential. The important thing to note is that the anatomy looks different when viewed from a different direction, and you should be familiarize yourself with the orientation of the structure before you start. There are some who advocate excision of the capsule of the hip. This is a very strong structure, and it seems a pity to dispose of it as it often supports to the hip post-operatively if correctly repaired. We are going to start off an anterior approach or Smith-Peterson approach. The disadvantage is it detaches a large portion of the origin of the abductor muscles from the iliac crest, that it can lead to an abductor weakness if not reattached in the correct position. It can also be difficult to align the femur for accurate insertion of the prosthesis using this approach. It is less frequently used for adults. It is used fairly frequently in children. The anterior approach, the incision begins at the middle of the iliac crest and is followed forward to the anterior superior iliac spine, where it is carried vertically down the thigh. Once the deep fascia is open, the dissection is carried on down in the interval between the tensor fasciae lata and the sartorius muscle. Care should be taken of the lateral cutaneous nerve of the thigh. The attachment of the gluteus medius and minimus muscle are detached to expose the capsule of the hip joint, which is incised to expose the hip. As illustrated, we started off in the middle of the iliac crest and towards the anterior superior iliac spine the interval between the tensor fascia lata and sartorius. Next, regarding the lateral approach. The skin incision pass more or less vertically down the side of the thigh. If the patient is obese, a slight superior curve to the incision allows the thick skin flap to hang down like an apron and enhance access. Once through the subcutaneous tissue, the incision passes directly through the iliotibial tract, parallel to its fibers. However, once the abductor and vastus muscles are exposed, the approach through the deep structure may be one out of the three types, or the modification thereof. First one, A. Watson-Jones approach, B. Hardinge approach, C. Trochanteric osteotomy or Charnley approach. For A. Watson-Jones, the incision through the skin and deep fascia typically curve forward in its proximal portion in the interval between the tensor fascia muscle and the anterior fibers of the gluteus medius muscle. Be careful of the distal end of the superior gluteal nerve in the upper reach of this incision. As illustrated, a facial incision is made into the fascia lata in line with the initial incision. This approach exposes the hip joint round the anterior edge of the abductor muscle. The anterior capsule is incised longitudinally to reveal the head and the neck of femur. If necessary, the anterior insertion of the gluteus medius may be incised to gain more exposure. Closure is by suturing the soft tissue. As illustrated, retraction of the gluteus medius and minimus reveals the pericapsular fat surrounding the anterior hip capsule. B. Hardinge approach. Classically, this approach exposes the hip joint by raising a flap through the bulk of the gluteus medius muscle in line with its fibers, just in front of its tendon, which inserts into the top of the greater trochanter. The incision in the muscle is carried distally through and in line with the fibers of vastus lateralis. As illustrated, incision is in line with vastus lateralis muscle. The incision is carried down through the anterior superior capsule, dividing or reflecting the tendon of gluteus minimus. The femoral head is dislocated anteriorly. Closure again is by suturing the soft tissue, although there is the opportunity of attaching the flap to the bone by way of drill holes through the bone. As illustrated, a deeper incision exposing the joint capsule. C. The Trochanteric osteotomy or Charnley approach. This approach removes the greater trochanter and gives good access to the operation site. In order to maintain the correct position and rotation of the trochanter relative to the femur, it is preferable to use a chevron type osteotomy. This can be performed using an osteotome or passing a giggly saw over the top of the retrotrochanter and cutting down on a Stemann pin inserted along the upper femoral neck. The left-hand picture depicts a giggly saw. This approach, because it does not traverse any muscle fibers, gives a secure, strong reinforcement to the prosthetic hip, provided the osteotomy heals. To encourage this, it is required that the divided trochanter is firmly reattached to the proximal femur. By using either two vertical loops as a tension band and a transverse loop held them all together, or a trochanteric fixation, example by using a box, cables and plates. The advantage of the system is that the muscle tension can be adjusted slightly one way or the other, but the disadvantage is trochanteric malplacement, and if the trochanter does not heal, the patient can be left with pain and lodging gait. The wires may also break and give rise to pain. As illustrated, the 4-wire technique of fixation of the trochanteric osteotomy. Lastly, regarding the approach, we are going to talk about posterior approach, Osborne or Moore approach. The skin incision initially parallels the line of the gluteus maximus fibers from below the posterior superior iliac spine to the greater trochanter and then curve vertically along the line of the thigh. Once through the skin, the fibers of gluteus maximus are split, identifying and preserving the sciatic nerve. As illustrated, a superficial dissection of the posterior approach to the hip joint. The short external rotators of the hip, the gemmelli, obturator internus, and if necessary, the tendon of piriformis are incised across their line to expose the posterior capsule, which is then incised to expose the neck. The head is dislocated posteriorly. Closure of this exposure is fairly straightforward, although it is often difficult to obtain a substantial closure of the short posterior muscle, which are then left to heal by scar tissue. As illustrated, the short rotators are exposed and incised across their line to expose the posterior capsule. Okay, I hope you have learned something from this video. This is all for today. See you in the next video. Take care and bye.